Okay.
Hi, everybody. It's Sheldon Lerner from Blue Sky Bio. I'd like to welcome everybody here, and hopefully this will be an hour or so well spent. Um, and I'd like to thank everybody who signed up and is here. Um, on the right side of your screen is a place to ask questions. You can text in questions relevant to this broadcast, to this live broadcast. And you can also email any questions to plan, Plan, at blueskybio.com, and either I or Michael Saltzman, who's a director of Blue Sky Plan, will be happy to answer any queries. As you know, we're an implant company first, but we're also the largest provider of guided surgery software probably in the world at this point in time, to the best of our knowledge. And hopefully everybody can hear me loud and clear. Like we have many implants, as you know, and we're always around to help and answer any questions that you might have. So again, text questions, text any type of questions on the right, and and if you have any questions about anything else, you can always email at plan@blueskybio.com. Okay, so let's get started with today's program. The idea behind the program is to um, is to provide a very easy step-by-step view of surgical anatomy and a little bit of histology to explain the whys and whats of placement. So it's not meant as a giant um, anatomy class that one would see in school or in a surgical program. But instead, it's designed to offer some ideas about basic anatomy and viewpoints so that anybody, including a beginner or a lab technician, could get involved and started with implant guided surgery. And so again, the two will be joined together. I know that many of the labs out there look at the word histology and get scared, like, why do you need to know about histology? I understand that, but it'll be very easy and very simplistic. And the philosophy behind it is that the main problem with guided surgery, why more people are not doing guided surgery, are the ease at which guided surgery uh, or the difficulty in terms of the planning and the availability of software. I think we've discovered that if we offer the surgery software for free, we take away a lot of the barriers. And but then again, most labs are averse at this point in time to making guides. Oh, there are very few true guide making labs. Most of them outsource it, and only about 5% of the docs actually do any planning. Forget about the number of guides that are made. So the question becomes, why? Well, part of the reason why laboratories and maybe some docs um, try to avoid planning or don't do guide planning or make guides is because the actual guided surgery for a novice dental laboratory, again, this is primarily geared to dental labs, but this is a good review of parameters for dentists who are just beginning their dental implant surgery protocol. Some of the histology and anatomy may be secondary to you, but it's always a good review. And so it's scary. There are blood vessels that you may or may not be aware of, and if you're not really good at or comfortable with a dental anatomy on a cone beam or a CT for that matter, you may not realize that implant placement near these blood vessels may be somewhat scary and sometimes life-threatening. And so you take a look at it and say, I don't want the responsibility. People who do guides, they're using your guides to do the surgery, and sometimes, if not planned appropriately, how am I sure that I'm in an area where I'm not going to cause the clinician following my guide or myself and my own guide to hit a vital structure? What are the areas, and so on and so forth. So that becomes scary. I've spoken to any number of people who would like to get involved in guided surgery planning, and have all said the same thing. I kind of know it, I'd like to get involved with it, but I am a little averse to the anatomy. Just scares me, and CT scares me, and so on and so forth. So a case like this, for example, should be relatively easy to plan. Yet most dental labs and most clinicians might be concerned about planning these themselves. And that's what we're going to look at. And of course, slides like this scare the living daylights out of people, and they should. There's a lot of anatomy to know if you're going to know anatomy. So let's simplify this in a very, very safe way. If you follow the protocols I'm going to outline today, you're actually going to be doing fewer cases in the beginning. And then you're going to be doing more cases because you will be more safe, and there'll be less reasons to be concerned, and then your reputation will spread in terms of sometimes the word no is the best word to say. So before we get into anything difficult or advanced, let's first learn how to walk with a little bit of guidance over here and take some baby steps to get to where we're going. So the first step is, the secret is to know where the edge of a cliff is and then to stay very far away. I mean, some people use guided surgery to get to the very edge of anatomy to be safe, and it's really not the way to go. The idea is to know where the edge of the cliff is so that you can stay away from all the scary anatomy and know where the anatomical landmarks for the scary stuff are, and then to just stay away. And so first we're going to start with the mandible and list three things, mandible lower jaw, and list three things to be concerned about. There are more, but these three major things to be concerned about. Where are the edges of the cliff, the edges of the disaster, and how far away do I have to be in order to be safe? And for those who are not used to reading a, used to reading a scan, this is a one of the areas of a cone beam or panorex, and here you see that the clinician has played. Doesn't mean this was guided; it was not guided, which is another reason to do guiding. And the clinician went all the way through the mandible on one side, drilled through the bottom of the mandible. That's what this little hole is in the side. Drilled way past the implant on this side, and the canal for the nerve is flying through here somewhere, and they did a good job of nailing it. It probably went through the submandibular fossa, which is number 2, and the entry of the artery in the middle lines, which is something you saw on the first slide. So let's take a look at that. This is a regular dental radiograph. This is not going to get implants. This happens to be imaging a third molar. But this shadow outline in a regular periapical is something called the submandibular fossa. And this is the outline of the mandibular canal. The mandibular canal is what provides innervation to the lips. If you go further back to the, not in the area of implant surgery, to the tongue, and doing and impinging upon the mandibular inferior alveolar canal or the mandibular nerve will cause either permanent paresthesia or temporary paresthesia, depending whether you put the implant in or not. Violating the submandibular fossa could actually be life-threatening, depending on what you hit on the way through. So it's important to know what these are. This gives you a viewpoint of some of the anatomy and blood vessels and arteries that are running through the area of near the submandibular fossa. It's not a good place to be. You don't want to be there. And the inferior alveolar nerve innervates the teeth, but it also has a major part of the branch exits and innervates the lip. So if an implant is placed down here, the lip on one side and chin can become numb. It's not a good thing to do. And obviously we want to stay away from this vital structure. Sometimes, unfortunately, you'll see in a moment that people like to use cone beams because the distance between the inferior alveolar canal and the amount of available bone is too small. They say, you know, there's only 8.5 millimeters of bone from the top of the bone to the canal. I think I'd like to do guided because I can then get within 1/4 millimeter of the nerve and be safe. As you'll see in a moment, that's totally not true. We'll talk more about that as we go along. And sometimes even if you don't place the implant too far close to the nerve, you just basically touch it. But unfortunately, the osteotomy is often longer. The bone osteotomy is often longer than the actual implant itself. So even if you look like you might have been safe on your final, or maybe just barely touching it, somebody may have actually hit a home run on the nerve when they were doing the surgery. So it's really important to isolate this, know where this is going to be, and keep yourself enough distance away to prevent yourself from running into a problem. So let's do this. Let's talk about the alveolar nerve for a moment, and talk about safe distances and so on and so forth. I just want to run through a couple of slides myself to see where I am. Okay. All right, fine. All right, so now, so the second part of this, besides the submandibular fossa, which by the way is right here. I don't know if you can see it. There's an outline right here. That's a submandibular fossa, which has a lot of contents you want to stay away from. To go through a full, thorough anatomy understanding of all the contents that are here that you want to stay away from requires a significant amount of knowledge. And I'm not sure that it's nice if the clinician knows what that is, but if you stay away from the edge of the cliff, which is to stay above the submandibular fossa, you will be okay. The same is true for the mandibular canal. In the entrance of in the area of the anterior mandible, here's a close-up shot of this area where this red arrow is pointing. There is often, not always, but often, a small blood vessel that enters. Here is a piece of a cone beam showing the entrance of that blood vessel. Now, many people say as long as you are anterior to the exit of the nerve, which is the mental foramen, somewhere in the premolar area. It depends on which, that's one of the reasons why you take a cone beam to isolate where it is. As long as you're anterior to that, you'll be okay. Some people talk about an extension of the inferior alveolar nerve. We'll talk about that later when we go through a cone beam ourselves. But in reality, there's another one that's where people who run into trouble, it's pretty rare to run into trouble, extremely rare to run into trouble. But unlike the inferior alveolar nerve, or the mandibular nerve, as some people call it, the people can run into real trouble in a life-threatening fashion. If they place an implant, and depending on the angulation, it just happens to run close enough to the entrance of this little incisive artery, close enough that the pumping and the pressure of the severed incisive artery in the center of the mandible, again, this close-up shot from the inside here, is enough to put pressure and pop this artery out. Now, if the artery is small enough, it'll cause a little bit of black and blue under the chin and the neck, a little bit of tongue elevation, and you might not even know what happened. But if the artery is large enough, and the patient has a little bit of hypertension, so that the pressure is high enough, the blood pressure is high enough, this little or medium, depending on where it is, size artery can pop out underneath the tongue. It can bleed under the tongue. That's where this is the front of the mouth. This is right under the tip of the floor, getting into the floor of the tongue. If this then starts to elevate the tongue because of all the blood that's pooling over here, this is an emergency and life-threatening condition which can lead to the patient's death. I actually had a friend that died. Thankfully, I wasn't the one who did his surgery, but he had this vessel severed. And even though he went to the emergency room, the clinicians on staff really didn't know what happened. And he bled out. His tongue was elevated and he asphyxiated, unfortunately. Terrible story, but one that's important. So the bottom line is that this is a really unusual situation I got from a friend of mine. This is showing these blood vessels entering laterally to the center. Again, this is a real outlier. You almost never see blood vessels enter left and right. Most of the time it enters in the center. A lot of the good clinicians who were teaching in the days before cone beam said never put an implant in the center. They meant because of the usual entry into the center. But once you're doing a cone beam and you're planning, you can go ahead and go lateral to it. So they would teach you never put one in the center and put them off to the sides for that reason. So these are the things to watch out for in the mandible. These are the edges of the cliff: the submandibular fossa, the alveolar nerve, or the mandibular canal, mandibular nerve, which we'll show in the cone beam in a minute, and the center blood vessel. if you stay away far enough away from all three areas, you will be fine. What's far enough away? So let's do that. Let's go now to an actual cone beam and see what we're going to do. Okay, let's look at a simple cone beam. And this is 3D view of a lowercase. I didn't really want that up there, okay. This is Blue Sky Plan, and there are other seminars to show you exactly how to use Blue Sky Plan. And what Blue Sky Plan does is it takes a composite view. In other words, it reformats it in a way that it's easy to plan. But typically, when you look at a cone beam, it looks something like this. And it's pretty easy to identify the nerve. It kind of drops off in here. You can try to find it by moving this out and in. I just was able to identify the nerve a little bit better over here by moving. This yellow line represents the center viewpoint of the area of interest, so I can move it in and out and help identify the nerve. I can actually use Blue Sky Plan to completely identify the nerve and see its exit, which we'll do in a minute. But it's really important to be able to identify a mandibular canal. It's really important to identify the submandibular fossa, make sure you're not putting the implant below into some side vital structure. So this is a 3D view of the jaw, and here is the submandibular fossa. The reason why it can get you into trouble is because I don't have a cross-section view over here. I will in a minute. Let me just tap this button and see. Sometimes what happens is the submandibular fossa doesn't look like this. Instead, let me go ahead and capture this. I'll show you what it might look like sometimes. Okay, so sometimes what might happen is that, let me get a pen for my, let me get a pen. Okay, so instead, the submandibular fossa may go, whoops, that's not what I wanted to do. Okay, this is what I wanted. A nice red pen, just like the English teacher used to write. Anyway, so sometimes what happens is the submandibular fossa looks like that. And when you look at the regular X-ray, it looks like the amount of room you have is pretty significant. It looks like you have all of this room to put an implant in when you look at it from this point of view. Your eye is here. But what happens when you put the implant in, instead of the implant being in bone, this is not here because it's really carved out, and you end up with when you take a periapical or regular X-ray, it looks like the implant's totally in bone, but in the meantime, you've now gone in 4 or 5 millimeters into the submandibular fossa. If you're lucky, you don't pop anything of significance. If you're unlucky, you hit an artery, and the patient becomes very unlucky at that moment as well. Does anybody have any questions on that? I just want to show you where I took the cut. I took the cut right over here in the area of interest of the mandible, okay? And you see this is a buccal lingual cut of this exact slice right here. Imagine a banana, and what I've done is I've cut the banana into round slices. That's what these are. And this section over here, I see my banana cut. Now, of course, the jaw is not banana-shaped. It's more pear-shaped, fatter on the bottom, skinnier on top. But, of course, it doesn't exactly look like a pear, and this would be the submandibular canal over here. So you would not, for example, want to put an implant for fun. Let's put an implant in over here. You wouldn't want to put an implant like that. Let's just outline this. Let's see if we can show the outline. See if I even know how to do that. Let's see where the. You know how to. I mean, I of course don't know how to do outlines and things like that. I know oh wait, implant, transparency. There we go. So here's the outline of the implant, and you can see I've made it go through a little bit. But when I look at the implant here in the composite view, it looks like it's in bone, right? It looks like I might even have missed the nerve, and I did. So when I'm looking at the composite view or any other view, I don't realize that, hey, wait a minute, my implant looks pretty good over here, right? But in the meantime, it's not so good, okay? I'm out a little bit, all right? That's what I meant, that you can look at an implant this way, and when you don't pay attention to it, it may not be exactly where you want. Okay, so this is what I mean. Here is an implant. Like I said, it looks great. The canal is running over here, but in reality, our implant is in the submandibular fossa. And if there's a blood vessel that happens to be up here, it's not common, but it can be up here. Then you have is it life-threatening? I have a friend of mine who actually was doing surgery and hit a home run on it, and actually had to go outside the mouth with this gigantic suture and come all the way around the inside and close it off. Now, people look at this and say, oh my God, I'm never doing implants. I could hit some structure in the submandibular fossa. The answer is the same as the picture of the cliff. Don't go there. That's why you have cone beams. Don't go there. When we teach live surgery and training, one of the things that we do is we tell people in the posterior, you're never putting in anything bigger than a 10 or 11 millimeter implant. As a matter of fact, we prefer 8s, 9s, and 10s. There's no reason to go any longer in the posterior. That's a whole different discussion to begin with, because most of the studies show that there's no reason to do an implant that's that long. Implants of proper dimension do very well in the 8 and 6 and whatever 6, 8, 9 millimeter, 10 millimeter category, no problem. But anyway, I just wanted to show you what I meant by submandibular. Let's remove that for a minute. And now we're still back in our anatomy situation. We have this little guy over here. Let's take away our composite view. Again, our composite view is they take all the slices together and they put together one image. So this is more like a periapical radiograph. And like I said, here I'm playing, whoops, let's put a point of view away again. Here I can play with this to put a dead center, and I can locate the mandibular canal. And if I want to, I can actually trace the mandibular canal, but just for fun, okay, let's not trace it, but here we have the mandibular canal, and it looks like it's which is where the contents of the nerve are, and I can see the trace of where the nerve is running. And you can see it's very close to the edge of the mandible over here, and of course, when we go look at this view right over here, you can see that the nerve is, actually, like we said, pretty close to the edge. So you can actually trace and make out where the nerve is running, and it doesn't have to be all the way down here. It can be higher up. But you really should, if you cannot, and this happens sometimes, I don't actually have an example here, where the mandible is not dense. It's not so radiopaque because maybe the patient has osteoporosis. Maybe they don't have osteoporosis. They just don't have a lot of dense bone, and they have a lot of cancellous bone, and it's kind of fatty and porous. And then you basically can't make out the mandibular canal. Sometimes you can't make out the mandibular canal in a periapical. Like, for example, I think I showed you this one. Let's just view the slideshow for a moment. And you can see that I was able to make out the mandibular canal in a periapical. Now, if I can't make out the canal in a periapical, and I cannot make out the canal in a panorex, and I cannot make out the canal on a cone beam, I should not be doing the surgery. Now, some people will say, well, if I've got this rule where they said if you have a molar in the back, and you can figure out where the exit is of the canal, of the mental foramen, and you draw a line from the mental foramen back, connecting to the roots, that's good enough. You know what? It is good enough, but I wouldn't do it anyway, because it becomes non-defensible in a situation where you did get a little too close. And again, we're going to talk about a little too close momentarily. One of the nice things about a cone beam is that sometimes you can't make out the canal on a panorex, but you can make out the canal on a cone beam image. And again, like I said before, one of the things to be aware of is that in a panorex, you can see 3D. So while you might be able to, I'm sorry, not packs, in a cone beam you could see 3D. So while you can make out the canal here, you will never know if this submandibular fossa happens to be cut back like this, so that you end up putting the implant, like I showed you before, all the way in, because of a lack of a 3D image. And again, sometimes you can't make out the canal. And you know what? Sometimes you can look at a patient in the eye if you're a clinician on this program, or if you're a lab technician on this program, you can call up the doc and say, listen, you know, it's a very non-dense bone situation. I cannot make out the canal very well, or at all. And if this was my cousin or my sister, I wouldn't do the implant, and walk away from making the cone beam, and walk away from doing the implant. And it's possible that some cowboy or cowgirl would be willing to go ahead and do that. But you know, there'll be other cases, and maybe it'll be fine, and sometimes it won't be fine. But you know what? It's very nice to be a cowboy, but my patients aren't horses, and I'd rather not ride on the horse and be a little bit safer, right? In the end, safety first. So that's one of the reasons why why the cone beam is important, and why the identification of this undercut right here is so important. This doesn't happen to be a very aggressive submandibular fossa, but I think you can see where this area is over here and where it is over here. Okay, so we did submandibular fossa. We talked about submandibular canal. And one of the tools you have over here is the ability to outline a canal in your software. So I just clicked on the nerve outline for nerve, and I can either do it as a composite, and you see I happen to be too high over here, or I can do it here when like I said before, I change the position of the image center, and I'm moving towards the front. But where is the exit of the mental foramen? My goodness, where did it go? And all of a sudden, I'm not able to see it so well. So what I'm going to do over here is I'm going to advance my image a little bit and see if I can see its exit. For some reason, I can't make it out very well. Actually, this is very good because I'm not seeing it very well. Let's go backwards a little bit. Somewhere over here is the exit. And I think it's so skinny that this is part of it coming out, and here is the rest. So let me trace it back a little bit. Okay, and let me go forward a little bit. So I can go ahead and make some dots over here. You see I can make my dots in different places. And let's see if I can find the exit. And maybe over here. Okay. Let's see on the. Let's turn this off. Now that I'm done, let me turn off and see. Sometimes it's good to see me have trouble with something also. And you know what? I got it. So this is in 3D. You can actually see the exit here. See, it's a little tiny one, and you can see it coming out in the right spot over here as well. So I was able to get the arrangement of the mandibular nerve out. So now the question is, how close to the mandibular fossa and how close to the mental foramen? I think that's a good question. And again, this is for the lab people and also for the clinicians. Very often I hear, you know what, I think I've got to do this case guided because there's hardly, I've got 8.5 millimeters of bone to the nerve on the periapical. It's too scary, I'm going to do it guided. First of all, guides are not accurate to 1/100th of a nanometer. They're accurate sometimes to 0.5 millimeter, sometimes to 1 millimeter. I would say 0.5 millimeter is a good number to 0.5 millimeter to a millimeter is a good number. But that doesn't mean that that's how close you should be, because there's something else about the mandible you should be aware of. It's not steel and it's not wood. It's like this spongy material, like you see over here. It's spongy. It's called cancellous bone. When you're drilling, first of all, your osteotomy burr is anywhere between 3/4 of a millimeter to a millimeter to a half a millimeter longer than the actual implant you're putting in. So if you're putting in an implant at 8 millimeters, for sure your drill is going to hit the nerve. That's number one. Number two, this bone is spongy, and there's blood inside. You might have done your osteotomy a millimeter away from the nerve, but when you place the implant, you're putting an implant into a cylinder filled with some blood, and as you're putting it in, you are compressing in a hydraulic fashion that blood back down again, and it's going to put pressure on the nerve. You can have a hydraulic paresthesia. A hydraulic paresthesia can last 6 months, which will be very unpleasant to you, your patient, to the doctor who's operating. It's not fun. So there is a number that I use in my brain, and that number is 2 millimeters. Now, there are cowboys out there who want to be 1/4 of a millimeter away. You know, I love horses from a distance. You know, this is a patient. So 2 millimeters is a good number. That means that there'll be a lot of cases that you have to say no to. But you know, that's important. So the question is, well, if I can't do an implant case with guided surgery within 1/4 of a millimeter of the nerve or a vital structure, what's the point of doing guided surgery? Well, the reason is to put the implant exactly where you had planned it. You know, much better than your eyeball could do. You can find out all the problems like submandibular fossas and so on and so forth easier. Your placement can be dead on, which reduces the need for custom abutments. You can certainly, I know there's a whole debate, custom versus stock versus custom versus stock. I'm an old timer. I come before there was even such a thing as a custom abutment. You don't use custom abutment in a severely angled situation. I think that people do a lot of it nowadays. If you put your implant exactly where it should be, the need for custom abutments is quite limited. It's not as severe as some people think, but that's a controversial subject for another time. So again, the idea is to keep that distance of 2 millimeters away from the mandibular canal. About the submandibular fossa, I'm going to step around here for a second. I want you to take a look, well, not here, but I want you to take a look at that area and notice how dense the bone is there. I'm going to keep stepping around, moving forward. No, that's not what I wanted to do. Okay, this is what I wanted to do. I want to move forward. Okay, so let me just step around, and I want you to keep watching how dense this little corner is. Now imagine you're doing it guided, so your drill is being held in place as you go down. But when you remember that the implant is larger than the hole in the bone, so that when you hit this area, the implant could be deflected towards the lingual. That's number one. Number two, you might have it guided like this in the proper position. But who says that the doctor will be able to actually perform the cutting away of bone that's this dense? Sometimes, not always, but sometimes the drills, it's so dense that the drill's not going to be able to do it. Now we happen to use direct cut drills, which are extraordinarily sharp, but still these are not drill presses. You know, there can be some deflection over here under the circumstances. So that's kind of important to be aware of. Let's see what else we have. Okay, so that 2 millimeters is important for the submandibular fossa and for the mandibular canal. Now here's another story, and this is the mental foramen. Now there isn't a, is there one here? Let's see. Let me just go over here for a second. Let me step back because I see on this one, I think there may be a loop. Do we have a loop here? Okay, let me go back to the exit of the mandibular canal here. Should be around here somewhere. Yeah, okay, here it is. So if you were only looking here at the exit right here of this canal, which is right here, then what you're missing, I'm going to start going from here and here. I think you guys see what I'm talking about. There's a little bit of an extension of that nerve towards the mesial, towards the center. Now that extension of that nerve, let's see, I'm going to step towards the center. And I still see nerve over here. You see it? So there's a slight extension of the nerve towards the center, past where the canal exits here. So that's called, they call that an anterior loop. And the end of the anterior loop is here. So that you could start putting an implant in 2 millimeters away from that anterior loop, or 2 millimeters above the anterior loop. But nevertheless, the canal went a little bit towards the midline away from the exit of the canal. Does anybody have any questions about the anterior loop? No? This is all very good. No problem. No problem. Okay. So let's see. Okay, so we've done the mandibular canal. We've done the submandibular fossa. Let's take a look at this case right in the center, and here we have a friend. As we said, this friend is an incisive artery off the, I believe it's off the lingual artery, and it is entering here, and or the mandibular artery. It's entering here. It's a pretty dense area. If for some reason there were no teeth here, and we're thinking about putting an implant over here, and it was superior, above this entry point, that's fine. You're not, even if you so if you put an implant, for some reason you wanted these two teeth were going out for some reason, and you were putting an implant in. I don't know why, but let's say you were. And you put one in here, fine. Everybody's happy, but not really, and it's nowhere near it, and you're good. If you wanted to put one here for some reason, I don't know why you would do that, but let's say you were doing that, that would not be a good idea. Okay? You can see where that would cause a problem. Perhaps the little bit of severed, now if it's severed in the center, it's not going to be enough to pop out the whole artery, but if it's close enough to the exit, within a millimeter or two of the exit, then it's going to cause a problem. Obviously, this is a relatively young patient with high amounts of bone with a large non-resorbed alveolus. You're not going to be anywhere near that when you're placing anterior implants. But it's an important thing to have in consideration. So again, to review, the three cliffs that we're avoiding, the three cliffs that we're avoiding are the incisive canal, I'm sorry, the incisive branch of the artery, the mandibular canal, and the submandibular fossa, which we said was back here, and that takes care of our cliffs. Anyway, so that's another one of the problems here. Dr. Gross is mentioning that even that doesn't. Sometimes what happens is because I think I mentioned that you can deflect the implant towards the buccal when you're putting it into the when you're putting an implant into the osteotomy. Even with an undersized drill diameter, it gets pushed back by the cortical bone. I think I mentioned that. Okay, let's see. We've got these three things in the mandible, and I think obviously there's many other things to talk about, but I wanted, while I have this image up over here, let's talk about this. We're going to go back to this in a minute. I would like to go back to the slide presentation. So let's go now to the maxilla. And then I'm going to talk a little bit about buccolingual plates as well, because the maxilla is not going to take that long. View. Slideshow. Okay. All right. So now the other cliff. The other cliff, I don't know about you, but I'm not afraid of heights, but this I would be afraid to do. Anyway, where is the edge of disaster on the maxilla? Where is the edge of the cliff on the maxilla? I think most people would be afraid of the sinus. You know, they're penetrating 1/4 of a millimeter into the sinus, and people get all bent out of shape. ENTs say things about the sinus. Sinus is a great mystery to many dentists. So there is a review on sinus anatomy and pathology that I posted on Dentaltown. I'll show you what the link is momentarily. Let me give you the link. I think I can give you the link here. 1 second. Let's do that on Dentaltown. I'll do that at the end. I'll try to give you the link on Dentaltown for a very long but very well done review of sinus pathology and anatomy. If you got that, then you'd probably be level with a first-year or second-year ENT resident in terms of what you would know. But again, the point of this conversation is not to tell you all the things of sinus anatomy, sinus pathology. After all, we're guiding not to enter the sinus. So unlike the other areas where I said to you 2 millimeters, I think you can go up to the sinus without a problem. Personally, I have no problem extending 1 millimeter into a sinus without a problem. Usually when I do, I end up trying to do a little bit of a lift, but that's a whole different story. That's my thing. But 1 millimeter, if you wanted to stay away, as somebody who makes guides, you wanted to stay away about 1 millimeter, that's okay also. All right, and if you want, here we go. Here's the Dentaltown. See if I can get. Let me see if I can get the. Here is. It's not working. Okay, no problem. I will get you the link for that later. There's a whole review of on the anatomy on Dentaltown if you're interested in that. But about 1 millimeter is fine. So let's. What I want to do now is I want to spend a little bit of time on a maxillary case, just so you can see it, and just so we can go ahead and identify the sinus. Okay. All right. Here's that case that I was showing you, and here is an implant already in place. It's planned. Let's sinus. This is a composite view of the CT, so you can see. Is that the composite view? Yeah, that's the composite view. So let me just go ahead and identify it by first. Let's see if I can get a whole view of the thing. Okay, here's a much bigger image, and we will now identify the sinus. I'm just taking a capture of a screen capture of it, and I'm going to take my handy dandy pen with my red mark. Actually, let me make it yellow just for fun. It might show up a little bit better. And here is the view of the sinus. Now, some people will say, oh my goodness, the roots are in the sinus? Well, sometimes what happens is, as time goes on, the root pops up a little bit. So if you looked inside the sinus, you'd actually see the root tips, but encased in bone. Here is another view, and these oh my goodness, this tooth, it perforated the sinus. That's not the case. In reality, the bone that's in the sinus goes around each root like this in a faint way, like that, around each root, and that's what it would look like. Of course, it's not yellow, but that's what it does. And this area over here is a septum inside the sinus. Again, for anatomy and understanding of what a septum is, I suggest you go to that Dentaltown piece. I'll give you the review. But again, as far as you're concerned, what you're talking about doing is not planning an implant to go up in here unless the doctor is prepared to do a sinus lift. Okay, and here we have one that's close by. It's not touching. And that's pretty much all you have to be aware of. What you don't see probably is another little septum over here. Again, the importance of a septum is a different issue. That's for surgical anatomy and not for planning. But if you wanted to plan a case that would be shy of the sinus, that would be a good cliff to stay away from. Now, there was something that I wanted to show you that is a misnomer, and we didn't talk anything at all about histology. And so I want to talk a little bit about that if I can, and show how the histology of the bone lets you know how far to stay away from the buccal and lingual. Okay, let's just spin around over here, and you can see that buccal lingually, there's a certain amount of room here for this implant. This is the buccal bone. This is the palatal bone. And so let's talk a little bit about that with a different case. And let's start with the case down. Well, actually, before we do the case, let's do the anatomy and histology. I think that's important. That's what we started with. Okay, so let's talk a little bit about the histology and how that relates to being a dental lab or a guide lab. Bone, generally speaking, has cortical bone on the outside and cancellous bone on the inside. Cancellous bone being spongy bone. Lots of blood vessels traverse here, and this is what keeps the bone alive. Now, if you put an implant in, and that implant obliterates all, here's a red piece, the implant is over here. If this implant, when it's put in, the osteotomy obliterates, now in this case it didn't, but if it would obliterate all of the cancellous bone, and you'd only be left with a dense cortical bone, then very often you'd be left with a lot of bone loss after placement. It's not the implant's fault, it's the osteotomy. So a lot of people have heard of the magic number of 1 millimeter of bone, buccal and lingual to an implant, or buccal and palatal to an implant. That's not at all clear that that's the proper number. The proper number may be actually closer to 2 millimeters. And that's because, especially in the mandible, and sometimes in the maxilla, getting to within 1 millimeter of the outside of the bone causes the bone to lose its blood supply. And over a period of time, when there's any kind of trauma or chewing, or the patient bites on a chicken bone, since there's no blood supply, the bone cannot recover from trauma. So there may be some bone loss to begin with, and there may be some bone loss with time later on. So having enough vital blood supply to the bone is important. And no, the gingiva on the top is not enough to be able to broadly give you the kind of healing you need, especially if there's a flap that's been made, to maintain the bone after an osteotomy or even after the implant placement when there is this dense cortical bone and no supply. Now, why is it that sometimes teeth can have a very thin, skinny piece of bone over it, and they'll do fine for the patient's lifetime? And the reason is because this is something that's half a tooth and half an implant, just for showcasing. The tooth on the left side of your left has a periodontal ligament space. Now, there's a micro blood supply in that periodontal ligament space that helps supply the bone that's next to it. When you extract the tooth and take it away, there's no longer a PDL, there's no longer a periodontal ligament space that's able to supply this bone. So that means after the osteotomy, all that's left is the flap of tissue above it and the cancellous bone. If there is a surgical flap on the outside of this implant, on the outside of the case prior to placing the implant, then that can be violated as well. So you're only left with cancellous bone in those circumstances. And that's why having 1 millimeter is not perhaps the correct number. I always shoot for 2. Now, here's the problem. The problem is that some of you are only getting paid to put an implant in, and some of you are only getting paid to put a guide in. And you know, that's a lot of pressure. And so you get a case like this, where the patient's gone through orthodontics and they have just a little bit of itty-bitty bone left. And you're looking at this and saying, geez, can I get an implant in over here? And so you go and say, well, Blue Sky Bio makes a 3 millimeter implant. Let's see, maybe I can get a 3 millimeter implant in there. And okay, great. So you go ahead and you pick a nice 3 millimeter implant, and you go here and you go, boom, and you line it up and you put it in, and it looks great, right? It's perfect. It looks good, right? Ladies and gentlemen, how much bone is there really here? It looks good, but let's measure, just for fun. Okay? What I did is I just clicked this little button over here, and it made it get as big enough for the whole space. Let's key in on it. And just for fun, so we don't move it by accident, let's right-click it and lock the implant in position, so moving the measuring tool and doesn't hurt it. Okay? And let's go ahead and measure how much bone we have right here. Wow. And I didn't go to the threads. I went to just below the thread to the body. I've got 1¼ millimeter here, and I'm being nice. Do you put one in? Do you not put one in? Most people would put a 3 millimeter implant in there and not give it a second thought. But this is a young patient. Is that really a good idea? I don't know. I'm not you. Would I do it? Not unless I did bone expansion, which is a much more advanced procedure. Other people would go ahead and do a bone graft. But I'm not comfortable. And sometimes people don't want to put in a 3 millimeter implant. Let's unlock it. Let's get rid of the measurement over here. Let's get rid of this number here. Wait a minute. How do I get rid of the number? Okay. Remove. Okay, great. Okay. So that they want to go ahead. Let's unlock the implant. And they say, you know what? I want to put in a 3.5. So let's replace the implant and put in a 3.5. You know, why not? That doesn't look so good. It looks good, right? Oh, I've got room for it, but not really. After the surgical trauma of the osteotomy and the placement of the implant, it's not clear that this is going to be a long and viable implant. I would definitely go for 3. 1¼ is not 2. You know, and this is the anterior. If something happens over here, it's not going to help. And if you've got accuracy of, let's say, 1/10 of a millimeter, 2/10 of a millimeter, all of a sudden maybe you have a millimeter of bone. And we're all in cortical bone. Notice there's no blood supply here. It's problematic. So that's why I'm showing you blood supply is an issue, and so on and so forth. What would I do here personally? As a clinician, I might go ahead and opt for, oops, I don't want to replace it, I want to get rid of it. I would opt for, maybe I would just take a 2 millimeter osteotomy burr and expand this out, leaving cancellous bone buccal lingual to the implant. Maybe I'd put a graft over here, but sometimes you need to say no. And this is a case that I would say 90% of all guide labs would do. Doesn't mean you shouldn't do it, just means I'm a little uncomfortable. And I think not only does the histology play a role here, but I think you can actually see the histology issue right over here in terms of the available bone that was left. I didn't see any cancellous bone over here, only cortical bone with a limited blood supply. So I just wanted to make that point. So now you kind of know that the 2 millimeters is where that number 1.5 to 2 millimeters, what it comes from. And it comes from the concept of, just get back to the slideshow. It comes back to the concept of histology. What's the blood supply for these things? Right? So now that we talked about buccal plate, what about the teeth? What's the number for adjacent to teeth? So here is a case that was put in. It's touching the PDL of the adjacent tooth. It might have hit a home run on the canal right over here. I don't know. This is not thankfully not one of my cases. But you can see that a couple of weeks later, this tooth has gone non-vital. So not only is this implant goodbye, but also the tooth is going to need a root canal. If the patient's lucky, that's all they'll need. But that's what happened. This is not an infection from the implant placement. This is a devitalization of a tooth because the bone was encroached upon and there's no longer a blood supply here. So of course there was some bleeding over here and some trauma just from placing the implant, and the bone could not recover in this area, leading to the devitalization of this nerve. The nerve died back, and it wasn't a good day. Okay, so so how much should there be between implants and teeth? If you look, there are a lot of people who say it should be 1.5 millimeters. Now, again, why is that? Well, the teeth themselves have a PDL blood supply. That's good. But they also have a cortical plate right next to them, which is not very vascularized. It's only being held by the periodontal ligament space. If you encroach on the bone so that there is no cancellous bone in between your implant and in between the adjacent tooth, then what's going to happen again is the possibility of bone loss along the tooth or along the implant because there's not enough blood supply in between or approximately between the implant placement and the tooth. Some people say that number is 1.5 millimeters. Me, I like 2. I know 0.5 millimeter is not going to make a big difference in people, but to me, I find that when I say 2 millimeters, then sometimes I get 1.5 millimeters. When I say 1.5 millimeters, all of a sudden we're talking 1. When I say 1, all of a sudden we're talking 0. So 2 millimeters is a good number, and I think that that will get you far less in trouble. So the 2 millimeter number between an implant and a tooth. Besides, you really need a little more than that just to get the proper emergence profile of the tooth coming up out of the implant as well. Getting too close to an adjacent tooth is not a great idea, because if you wanted to get over here, of course the tooth that's next to it does not have a flat profile. It also has some emergence profile and some shape to it. You're not dealing with flat planed objects. I forgot the video game that's all squares. I think it's Minecraft. I'm sorry, I don't have teenagers anymore in the house, so I don't know what the names of video games are. So the world, we don't live in a Minecraft world, so we have to account for shape and profile and so on and so forth. So 2 millimeters is a minimum of 2 millimeters is a good number. What about between implants? Well, you don't have PDL there, and if the implant needs 2 millimeters of bone in between it and the buccal plate, what does it need between 2 adjacent implants? So the answer should theoretically be 2 millimeters, right? But it isn't. The answer really is it should be 3. And the reason is, number one, during placement of the implant, you have to have enough room of vital bone left after the osteotomy. You probably get 0.5 millimeter of dieback of the bone to begin with, just in the fact that it was drilled. 1/4 millimeter, something is not happy and clots during the placement of the implant. And so you have to leave a little bit of room for that. In addition, the gingiva in between the implants have to have its own base of adequate blood supply to be able to remain. And sometimes when you put implants too close, the papilla between the 2 implants disappears. So it's got to be wide enough to be able to support the gingiva above the bone and wide enough to allow blood supply. So 3 millimeters is the number that people use. So, and that's the absolute minimum. I personally like to go 4. Extra 0.5 millimeter on each side. That's my personal preference. You can do with it, I know this says 3, but I like to choose an extra millimeter just for emergence profile and also for trauma just from the osteotomy placement. Okay. Let's see if we have anything else to add. I think we've pretty much covered what I wanted to do in terms of the presentation. Again, the idea was to identify the cliffs that we're talking about so that we don't get too close to the edge, and so that we stay away from the edge of the cliff. I'm going to go ahead and I'm going to look for the dental town. Give me a minute and I'll get the dental town A to Z business, and we'll go from there. Let's see if I can do that. Okay. All right. Sinus lift from A to Z, and let me see if I can go ahead and put that into our little hangout over here. How do I do that? Okay. Let's chat. No, I can do that from a different one. That's why I have a different computer up. Give me a second and I'll do that. Okay, don't you hate when the clinician doesn't have everything ready for you? That's terrible. All right. Take me 1 minute to get that, and my recent activity. Take me about 1 minute. In the meantime, if you have any questions, that would be great. All right. go to here, and I am going to somehow be able to do the chat. Right, here we go. Hopefully that went to everybody. Michael, did that go to everybody? You there?
Yeah, I'm here. Yeah, I think that worked.
Okay, great. Well, if there are any questions, that would be great to know. Are there any, Michael? Do we have any?
Yeah, you have a question regarding the ideal or preferred implant diameter.
There isn't any. Isn't that great? Let's do it from two aspects. One is the biological aspect, strength aspect, and emergence profile aspect. And let's go to anatomy first. Obviously, the preferred diameter should leave 2 millimeters at least of bone available on the buccal and lingual after implant placement. Then to do the subtraction, you'll see how much it is. You'll find that generally speaking, even clinically, if you thought you were putting in a 4, you really should be putting in a 3.5, going lower. If you thought you were putting in a 4.5, you should be putting in a 4, and you should be putting in a 4. So you'll see that once you start using the 2 millimeter rule, your diameters will get narrower. Then you're left with emergence profiles. Now you need to you don't want your crown to look like a tomato on a stick, and you don't want to be putting 3 millimeter implants in posterior regions if you're not splinting. And so you'll end up dropping your implant in a little bit subcrestal, below the bone level, so you can get enough running room to be able to go out to a proper emergence profile. Now, for example, in the Astra system, the 3.5 and 4 millimeter implant have the same exit diameter coming out of the implant, and the same is true for a 4.5 and a 5. So the diameter is not necessarily related to the emergence profile. For example, there's something called an ankylosing implant. We don't make a compatible implant to that, but it has, I think, a 2.5 millimeter exit diameter for all implant diameters. And what it does, in order to be able to accommodate that, it puts the implant subcrestal, below the bone, 2-3 millimeters, to get enough running room to do that. So you can do that choice. But the diameter is, nowadays, I shouldn't say nowadays, many implants are strong enough for molars, even at a 4 millimeter diameter level. The material, at least ours, the materials are better, the thread depth is better. It's not like the old days where you needed a 5 millimeter or 6 millimeter implant to support a molar. So I think first is anatomy, because you want that implant to survive. And generally speaking, implants are strong. For example, in our Max implant system, the abutment of the Max, which is only a narrow platform compatible with a narrow platform active, our narrow platform abutment is as strong as the regular platform abutment with our more advanced engineering, so that you can have one platform support a molar, even though it's an NP. So I think it's important to know your implant that's going to be placed. It's important to use an engineered implant that's good enough. And then the world is actually moving shorter and narrower, except in immediate placements for molars. So I think that's an important thing to be aware of. Anything else?
Yeah, there's actually a question that came in regarding the shorter, narrower implants and what your opinion is on them.
I think that the world is moving shorter and shorter. I think that most of the studies are showing that there's no benefit to an implant that's longer than 8 or 10 millimeters, because most of the studies are showing that the pressure dissipates within, I think 95% of the pressure of an implant is gone by 8 millimeters. The rest of the few percentage is down by 10 millimeters, and after 10 there's no pressure transfer to the apical threads. So from an bioengineering perspective, there is no, I know this to a lot of people on here, it might shake them a little bit, but there is no advantage to an implant longer than 10 millimeters. Now, even without taking a stand, I can tell you that in the more than a decade of being available for a commercial basis of Blue Sky Bio, we're seeing that the average length of our implants is going shorter and shorter and shorter. It used to be the #1 selling implant was a 12. I believe that now it's a tie between the 8 and the 10. So the world is moving in that direction, and not necessarily guided by the research, but guided by the experience and supplemented by the research. So shorter is definitely happening. As far as narrow is concerned, that revolution is up to a point. And it's up to a point in terms of its engineering. An implant that's narrower than 3.5 millimeters, you start getting into issues of being able to be used in the posterior. I think 3.5 millimeters currently is the absolute limit for a premolar sized implant, and the reason why I know that is based on our cycle test studies. We don't just clone, we test, and we test for a very long time. So we know that when we make a 4 millimeter implant, that implant can hold a house. But when we go down to 3.5, that's not the case. They're still stronger than the abutments, so the abutments will fail first, which is good. But nevertheless, that's what the issue is. The issue is the amount of bone that's attached to the implant, and that'll have to do with the thread design. And the other will be, as for example, here is these are Biomax implants. I can't make this much bigger, but you can see that the thread design is pretty deep for a 3.5 millimeter implant. So these threads act a lot like a pontoon on a canoe. So I actually have a whole lecture on that. So when you have lateral force that's hitting during function, which is not up and down or pull-out force, but it's a lateral force, the deeper threads transmit that force down into the bone. So if you have enough space between the threads and enough depth of the threads, you take a lateral force and you convert it to a vertical one. I think that's an engine. Many of the implant companies are switching over to our thought and that thought of having a deeper thread pattern to transfer load, and so that shorter implants work out better. And of course, better engineering means that some of the skinnier implants work. But it's a limit, and currently, I know maybe things are going to change in 4 or 5 or 6 years, but the absolute limit for a first premolar or a premolar would probably be 3.5, 3.7, a molar about 4, 4.3, 4.5, in that range. And nowadays, there's really, I don't see much of a reason to put in 6s and 7s. We sell a lot of 6s and 7s, but those are used in immediate molar sites. But that's my opinion. You know, a lot of people have opinions. Who says mine is correct? Any other questions?
I think that pretty much wraps it up. I think we're also past the time.
Okay, so plan at Blue Sky Bio is where you would want to send your send any other inquiries, and we're always available to help you get on your way in terms of becoming a plan company or to plan your cases. And thanks everybody for spending the evening with me.
And everybody's encouraged to enter their information into the webinar attendance form to make sure you get the CE credits. Have a good evening. Thank you very much.